Smriti Madam is part of Pallium India. She is an internal faculty. Actually, she is actually head strategic programs and partnership and director programs. Welcome you, Madam, as faculty to the program today. Thank you.
Thank you so much. Thank you, everybody. I think there are people still coming into the room. So do you want to just take a minute till?
Yes, ma'am. I think they are joining.
All right. Okay. I'll request cameras on, please. All right. So why are we doing a session on addiction and substance use disorders for a palliative care program? Did anyone have that question before we came into this session? Why are we doing addiction and substance related disorders? You've all been here with us for a few sessions now, and I'm just wondering if you have any thoughts on this. Okay, so palliative care is the prevention and treatment of suffering. If any of you have experienced addiction and substance use disorders in your ecosystems, you'll understand what a lot of suffering it is. There is also the fact that in palliative care, we use medicines that come under the category of internationally controlled medicines. And we rely heavily on medicines like morphine and other opioids, which are highly controversial family of drugs. And I will also be talking to you about that a little bit, because one of the major barriers to access to opioid analgesics for pain relief in our country is the idea that it is addictive, the idea that it is a drug and it can lead to dependence and so on. So there are several reasons why addiction, substance use disorder, and what we're doing in palliative care have a lot of things in common. And today's session is more generic. I will invite you to post your questions if you have. I'd also like to say that the session will take on different perspectives from the point of view of what addiction and what substance use disorders really mean in a wider setting. What are some of the individual, how it manifests in individuals, how it impacts families, what are family dynamics that also contribute to substance use disorders. And after that, we will be going into more generic, what are some of the misconceptions, what are some of the facts. And finally, I'll be taking you into the palliative care situation and where we are today with access to controlled medicines in the world. So it's a fairly layered and nuanced session today. And I hope some of it is useful to you by the end. And I hope it also clarifies a lot of the myths and the misconceptions around controlled medicines, dependence, addiction, and so on. So I'm going to get started. And as always, I will ask you to please use the chat box freely, either to ask questions or to reflect, give your comments and so on. Yeah. All right. So let's get started. My first question to you is, what is addiction and who is an addict? And you can start using the chat box, please. Okay, what is addiction and who is an addict? And we tend to use these words quite loosely in our assessments sometimes, unless there has been some training there. So this is just something for you to think about. Who would you categorize this person as? What is the first thought that comes into your mind when you see this person? You can feel free to unmute yourselves, and you can also please use the chat box if you like. Abuse of any substance and cannot exist without it is an addiction. Thank you, Swarnalata. Okay, so addiction to something can be understood as that extremity where it starts hampering the daily living. Thank you very much. Avantika, you want to say something?
Yeah, I was about to say the same thing. Addiction of anything which is harming our day-to-day life and our family life.
All right. Okay. So when this picture you see is, what does it evoke in most people in this room?
Addiction of drugs.
Yes, addiction of drugs. Anything else? Anything else that comes together in your mind is what might be this person's story?
If we talk about the story, it can be due to the family issues, he is prone to that, or the friend circle, environment, or maybe any kind of a disease that pain is not bearable and he is more inclined towards substance abuse.
Thank you, Avantika.
This is what I observe in Sneha Achal.
Thank you. Yeah, we all bring our own experiences to what we are talking about today. So anyway, so typically somebody like this would also be avoided in society. You know, you wouldn't encourage your own family members to really hang out with somebody like this. There are various nuances and layers to it. Second, what about these two people? Do they look like they might have an addiction? Do these people look like they might have an addiction?
Not drug addict anyway, but maybe running.
Addiction to fitness,
Yeah.
to healthy athletes.
Yeah.
So thank you, Saju. That is very important. I want to highlight something. This picture and this picture, the difference is what the addiction is visible. And we're going to be talking about addictions that are not necessarily visible and therefore less judged. Okay, so so this is just to set the stage that addictions come in all kinds of forms. They come in all kinds of you know, they manifest in different ways, and just what you see on the surface does not tell you the whole story. So we're going to go into what some of the threads of that story might be for different people. But first, I want to start with a case. And can I have a volunteer from the group to please read out the slide? Somebody who hasn't yet spoken, perhaps? Would anyone like to volunteer, or shall I call someone out?
Okay, can I read?
Please go ahead. Yes, go ahead.
Mrs. A is suffering from advanced breast cancer. She is 50 years old. She is in excruciating pain almost all the time. She is from a middle-class family. Husband works in a bank. He is away at work all day, and when he comes home, he drinks and he is barely communicative. There is a history of violence in the family, which is now lessened after Mrs. A's illness. The older son is about to get married. He's 25 years old. He wants to move out soon, but cannot proceed with his plans because of his mother's illness. The younger son is in college. He has been barred from his exams for non-attendance and is moving with a bad crowd. What are your first thoughts about this family?
Let me put it into context. When I say thoughts, I want you to think about who here needs help.
Everyone?
Everyone. Who would you prioritize?
Maybe Mrs. A first. But I think everyone has their priority. So you can't say everyone, she has her illness, he has his alcohol addiction, the Mr. A. The elder son has his own problems, not able to decide. The younger one has his own abundance of problems.
But if you were, but yes, we would like to fix everything. But if you were to focus on one thing, what would you focus on?
Maybe Mrs. A first.
All right. Can I hear from the others as well, please? Who would you focus on if you had only very limited
I
time?
think
Sorry,
the younger son in college.
you'd focus on the younger son. Why is that?
Your voice is breaking.
Is it my connectivity?
Your voice is breaking.
No, ma'am, you're audible. It's not.
Saju, yeah, okay, all right. Saju, can you just check your connectivity, please? I did hear that you said that you'd focus on the younger son. I'll come back to you if you can you hear us now?
Ma'am, you're audible.
Yeah, I can hear him.
Can you tell us why the younger son?
Because Mrs. A is anyway down with cancer and she's 50 years old. And somebody has to look after her. At the moment, the younger son needs attention.
Okay. I think we're having some difficulty with your connection, but I can see that other people are also weighing in on this. Would anyone else like to take a shot at sharing what who they think should be getting the priority in terms of attention?
I think the husband, because as the father and the husband is a main caregiver as well as the protector of family. If his condition is good, then he can take a good decisions about the family as well. Also, he can take care of his ill wife and younger son who is in college. So I think the father.
Thank you, Pankaj. Thanks a lot. So I'm going to stop sharing for a minute so I can see more people. What is this an uncommon case I just showed you?
No, it's
Do you
very
think this is
common.
it's very common? Yeah. So you have somebody there with a serious illness who will probably benefit from palliative care. You have someone there with an addiction. You have somebody there where there is violence, probably because of the addiction or because it's exacerbated by it. You have somebody who is probably very anxious, cannot get on with his life because he has obligations. You have a fourth person who is the younger sibling who has probably developed all these other behavioral modalities of coping, possibly at risk for addiction as well. Now, the mother might need morphine. Are you going to, how do you feel prescribing, making sure that morphine is available to this woman in the form of tablets at home? So, these kind of things impact our decision making as well. Now, I would be very concerned about saying, okay, I have to control this woman's pain, but I'm going to give her 40 tablets of 20 mg morphine to keep at home because she lives far away from the palliative care facility so she can control her pain. Yeah. So what I'm trying to say is that these are issues that we come across very often. And what tends to happen in a lot of times is if you have somebody with cancer and if you have somebody with an addiction, there is a judgment that comes in towards the person who has the addiction. I've heard a lot of social workers, not necessarily in Pallium, but a lot of other places say, we go there, but her husband is completely useless. All he does is drink and sits in the corner and he's of no use to anybody. In fact, he's a big problem. So there is a value judgment we attach to addiction versus a serious illness. And even in illnesses, we have a caste system of which illness is considered more, acceptable, what has a stigma associated with it, what has whatever else associated with it. So that's what we're just trying to highlight, that yes, families are seldom simple, most of them are complex. And then there is a tendency to prioritize in our head who is more deserving of compassion and treatment than others. Now, I'm going to come back to this. Addiction is equal to the dysfunctional dependence on a drug. That is something that many of you have also said when I asked what addiction was. But this particular interpretation of a dysfunctional dependence is just 100 years old. 100 years is not a lot. If you think of our history, it's not a long time. Okay. The word addiction only referred to an activity that someone was passionate about. That was the origin of the word addiction. The root of the word adicere means to assign a habitual activity, a habitual activity with a positive purpose. So it was a positive thing when the word first came about. The Romans actually came up with the phrase addictus and referred to a person who had defaulted on a debt and then was assigned to his creditor as a slave. Now, if I can't pay my creditor, I'm assigned to him as a slave. So the modern interpretation, a slave to a habit. So, I mean, this is just some trivia. It's just etymology of the word. Now, why is it important not to use drugs? Why is it important not to use drugs? because it's wrong. Is some people might think it's wrong. Using drugs. Just to say why it's not a good idea to use drugs.
Smriti ma'am,
Yes.
ma'am, your voice were shaking. Hello.
Oh, can you tell me now why not to use drugs? It may seem like a very silly question, but let's just list out why we think it's not a good idea to use drugs. If it is not regulated properly, it will have severe adverse effects. Judgment also, okay, fine. Sets in for addicts versus illnesses. Situation upon themselves. All right, that's an important point, Harpreet, about the fact that the situation has been brought on by themselves. We'll come back to that. Okay, why not to use the drugs? Because some people might think it's wrong. Some people says just people shouldn't use drugs because of many other reasons. Because it's not natural to use drugs. It's a bad thing, and because they will kill you, like adverse effects. Okay, but why is it that people still use drugs? It could be because it's part of a culture or a subculture. Can you give me an example? Do you know of any cultures or subcultures that have some drug use as ritual, as ceremony, as celebration?
Having bang.
Bhang, yeah. What else?
Peer pressure.
Yeah, because it's integral to social groups or social activities also. Just to also remind you that alcohol is a drug as per classification.
Yes.
So let's not forget, let's not only think of the heroin and all of those things, okay? So yeah, because it's integral to social groups or social activities. Yeah.
Ma'am, we have some messages in the chat box.
I can see that. Weed, charas. Yep. You don't have any control on yourself when you start taking drugs, severe addiction. I think that was in response to the previous slide. Okay. Some people take drugs because it improves their performance. Can you name some drugs that improve performance?
Some college students use something to study and have a better, what do you call, concentration and all the stuff. I'm not sure of the name.
Yeah, absolutely.
So that they can remain awake for 24 hours, 48 hours.
Yeah. Anyone else who uses drugs to enhance their performance? People in sports. We keep hearing about these controversies quite often. Somebody was disqualified because they found a performance enhancing drug. Yes, athletes. Okay. It enhances positive and desirable feelings. People feel better when they take a particular drug or when they smoke something or drink something or eat something. Because it prevents or diminishes negative and undesirable feelings. So some drugs might make you feel better. Some make you feel it numbs the pain. There are different effects. Some people just need to take it because the withdrawal symptoms are so bad. If they stop taking a particular drug, the withdrawal is so bad that they have to taking the drug again can make the withdrawal symptoms better. Heroin is a prime example of that the withdrawal symptoms from heroin are so torturous that finally the person just can't, they don't want to ever experience that. Some people just do it out of curiosity. And this could again be, it can be peer pressure. It could be just a sense of, I need to just see what this is all about. I'm curious about it. Now, some people do it because it's just plain old fun. They have fun doing it. Okay. I want to just quickly zoom out for a second here because there's a lot of stuff out there right now about drug use and things like that. I also want to just quickly bring to you the thought. I want to place the thought in front of you that drugs and the use of drugs across the world is a highly politically charged subject. It's a very, very politically charged subject. Okay, and it's not just in the personal space anymore. It has never been only in the personal space. It is always been, it has occupied a major space in social and political settings. Now, these are two books that I would encourage you to read, because it also has perspective on how the use of drugs has specific impact on certain communities more than others. The fact that it was Opium Inc. is something that an Indian author wrote, Thomas Manuel, and it is a fantastic book about the history of opium, the opium trade in India, which pretty much fueled empire. But at the same time, they knew it was, but they traded in it. You will find in this book that entire history, a huge part of history in India, as you studied it, might have left out the part that the opium trade played in it. Anyway, so what I'm trying to say is that it exists in a massive context. And indigenous cultures, like some of you have mentioned in the chat box, around the world partook of substances in ritual, food, and ceremony, not just in India, in all over the world. And the word drug is something that only appeared after colonization, when there was a commodification of certain medicines and into drugs. Yeah, and the war on drugs rhetoric, which emerged from the US in the 1960s, 70s, and 80s, pretty much shaped the current drug policies around the world. What drug is legal, what is illegal, what is licit, what is illicit. All the current drug policies in the world are heavily influenced by this rhetoric of a war on drugs. And it is not a straightforward, subject as many people would think. It is very convoluted. It has a lot of different aspects to it. So I would encourage you, if you are interested, to also, look at the broader picture. And these are two great books to start with. Now, coming back to the patterns and types of drug use, there are several patterns. There are people who have never taken a non-prescribed drug or used to take drugs but stopped, and they don't want to use them ever again. So people who've had the experience. There are people who will absolutely not buy anything that is over the counter without a prescription. So there are those people who are extremely careful. There are those that are experimental, trying a drug out of curiosity or because friends are using it. And this may be only once, they may not like it, and then they stop using it, or it might be for a short period of time. I think a lot of college students also go through this phase, and then they grow out of it, and then they move on. I mean, it could be at any phase in your life, really. Recreational is using drugs occasionally and in specific circumstances. That is when you're with a particular group of friends or in a particular kind of social event or on weekends. That is recreational use. Okay, so that's what we mean by recreational use. And some drugs are illegal even when it comes to recreational use. Instrumental is taking drugs to accomplish a task or a goal. And when the goal is achieved, the drug use stops until a similar situation occurs. We talked about performance enhancing drugs for athletes. We've talked about, there's also drugs for virility and things like that. I mean, that's how they're marketed as well, right? So using those drugs in very specific ways to make a particular task easier to achieve. And finally, there is dependence, which is a pattern of frequent, heavy use, usually for a long time, and it results in a diminished ability to control how, when, and where to use. And this is where it becomes dysfunctional. You have no control over it. And as Tabinda had said, you lose control after a period of time. And when drug use stops, the cravings are experienced and the drug withdrawal symptoms occur. So these are the varying levels. When we visit people in their homes, especially in palliative care scenarios and things, it is very essential to make this distinction. Is the person a recreational user, an instrumental user, or is he dependent? Very often people just get clubbed as addicts, and that's the end of that. And that's not right, that's not fair. Okay. The WHO Expert Committee on Drug Dependence in 1973 categorized drug use patterns into 3 categories: experimental, recreational, and dependent. But in 2006, this person called Good actually came up with 4 more things: legal and instrumental, that can be prescribed to treat or relieve. So these are drugs that we use to treat or relieve any sort of symptoms or suffering. Legal, recreational, tobacco, alcohol, caffeine, these are all drugs. They come under the Drugs and Cosmetics Act, but these are legal and they're used for recreational purposes, and they're used to achieve a certain state of mind. There are illegal and instrumental, that is taking illegal drugs to accomplish a task. And there's illegal recreational, taking illegal drugs for fun or for pleasure. So these are the different ways in which people take it. So not all substance use is illegal, not all substance use is recreational. So there are these different categories as well. What we talk about dependence as per the ICD-10 is a cluster of physiological, behavioral, and cognitive phenomenon which the use of a substance or a class of substances takes on a much higher priority for a given individual than other behaviors that once had greater value. So what it's basically saying is that dependence syndrome is when the need for the drug or the substance takes on a much higher need than anything else, and it overrides other activities which once had great value. We'll talk about that in a little bit. It's very important to remember that you cannot interchange the words dependence, abuse, and addiction. They are three different things. Dependence, addiction, and abuse are three different things. And they're not interchangeable. And a person can be dependent on a drug, but not an addict. Can you give me some examples of a drug that you're dependent on, but you're not necessarily addicted to? How many of you here take medicines for high BP? Or for cholesterol? How many of you take insulin? You are dependent on that drug for your health. Would you say you're addicted to it? Are you addicted to your cholesterol pills? I don't think you're addicted to it. You're dependent on it. You need it. Yeah. So that's dependence also. Okay. Coffee. Well, yeah, that's an outro. We'll come back to why it may not be such a bad thing. Okay. A person who has developed a tolerance to a drug need not be addicted. There are medicines that if you take over a prolonged period of time, you need more and more for the ceiling effect to wear off, right? So does that mean you're addicted? You're not. It's just that your body is getting used to it, and therefore you need higher doses of that same medication to have the same effect. Withdrawal symptoms do not indicate addiction, and they can be experienced with a drug that is not addictive. So I know there are lots of different interconnecting wires here. So withdrawal symptoms do not indicate that somebody is addicted. It could happen with a drug that is not an addictive drug. Some examples: TB medication. I remember I had tuberculosis when I was working. I contracted tuberculosis in a children's ward many years ago when I was young, and I had to undergo treatment for TB for 9 months. The drugs were very strong, and they don't taper you off the medication. You stop at the end of it, and for about a month, I couldn't lift a cup of tea without my hands trembling. There are other kinds of withdrawal symptoms that people experience when they have been taking heavy doses of medication for something. Psychiatric medication also has side effects, as well as, you have to wean off certain medications. So you have these withdrawal symptoms. It's not necessary that you are addicted to the drug. So it's very important to make that distinction as well. Okay, now what addiction really has is these 4 things. Compulsive engagement with a particular behavior or preoccupation with it. You're preoccupied, okay, and it's compulsive. You don't really have control over it. You have impaired control over your behavior. There is persistence or relapse despite of the fact that you know it is harmful. Somebody who is a serious alcoholic knows it's bad for them, but they will continue to reach for the alcohol. A smoker, everywhere you look, there are signs telling you that smoking is bad for you. It gives you heart disease, it gives you cancer, it gives you this. Even the cigarette packets have those horrific images on them, right? But does that stop a smoker? No. That's addiction. Intense craving, dissatisfaction, irritability if the drug or activity is not immediately available. Okay, so compulsive engagement with the behavior, impaired control over the behavior, persistent or relapse, persistence or relapse despite evidence of harm, and intense craving. If these 4 things are there, that is an addiction. Okay, that's something for us to also remember. Even tobacco and gutka eaters, absolutely, you can't stop. You can't stop it. Yeah. Now, this is a lot going on in this slide. Addiction is not, people think it's a choice. People choose to become addicts. No, absolutely not. Addiction is one of the most complex conditions and with very complex interactions between people and the environment. There is a biological component. I'm going to talk to you about that in a minute. There is a chemical component. There is a neurological component. There is a psychological component. There is a medical component to it. There is a very huge emotional component to addiction, social, political. Why do we say political? Erstwhile colonies have major issues with addiction. Marginalized communities have a major problem with addiction. There is a socio-political context to that, and let's not make any bones about it. Like if you look historically around the world, people who were colonized aggressively today, those are communities that have massive issues with substance use disorders and so on. There is an economic component to it, as we all know, and it's not necessary that only people from a certain economic class or category are more likely to be addicted, but there is an economic component. We'll talk about that. And there is a spiritual component in terms of meaning, hope, connection. Okay. And I'm not going to go through all of it, but I'm just going to highlight some things that I think are absolutely essential. There is a strong relationship between addiction and trauma. And there's Dr. Bruce Alexander who talks about this. He says, even the most harmful addictions serve a vital adaptive function for dislocated individuals. Now, I don't mean dislocated only physically, also emotional dislocation. And there is a strong component between trauma and addiction. I'm going to talk to you about that now. How many of you have heard of adverse childhood events, ACEs? There are 3 kinds of ACEs: abuse, neglect, and household dysfunction. Okay, you can read up about adverse childhood events. It's a very, very interesting study. It was done by the CDC, and this was a landmark study that was done. Now, this is basically the categories of potentially traumatic events that occur in childhood between the ages of 0 and 17. So there could have been abuse, which was physical abuse, emotional abuse, or sexual abuse. There could have been neglect, physical neglect, not enough cuddling, not enough hugging, not enough, physical safety. There could have been emotional neglect. They get all their food, they get everything they need, they have all the material stuff, but they don't have the emotional, intimacy. They don't get that as children. And there could very well just be household dysfunction. There could be a mental illness in the family. And I don't mean like, extremely visible mental illness. It could be something else. Incarcerated relative, somebody who's been engaged in criminal activity. It could be a mother treated violently by the father, or anyone in the family treated violently. There could be somebody else in the family who has substance abuse. There could have been a divorce or a breakup or conflict in the family. These are just examples, but there are largely 3 categories. Now, what the ACEs theory says is that as a child, if you are exposed to these kind of experiences, your risk outcomes become higher. So in terms of behavior, there's a correlation between people having gone through these ACEs, having less physical activity, tend to smoke, might reach for alcohol. There is more chances of drug use. There's more chances of missed work, either because of not being able to commit to a job or just not being motivated or whatever. And there could also be physical and mental health issues like obesity issues, weight issues, other eating disorders. So there are various things that happen here. I mean, I'll let you read up on this. But what is really interesting is that the more difficult somebody's childhood, the higher the score is likely to be. And the higher the number of ACEs in a child's life, higher the risk for various health problems later. Okay, so let me just put this in context. Now, this is where this is where I'm taking you right now. Adverse childhood experiences, which is the third from the bottom. I talked about the socio-political context, okay, so let's say generational embodiment, historical trauma. Let's talk about people like who had to be refugees from their country and had to move to another country under very traumatic circumstances. They probably end up in the fringes of society, and their social conditions are not great. They have to start from scratch. They're probably impoverished. So those are some of the historical things. Now, in these kind of households, also there are higher stressors and things like that. Not to say that you don't have it in families which have been well settled in the same place for a long time or whatever. But this is where I'm taking you right now. So in any household, there's likely to be some sort of adverse childhood experience. Now, the younger the child, the more it impacts their neurodevelopment, their cognition. This is a time of intense cognitive development, how they regulate their emotions, how they respond, fight or flight, how they start learning how to problem solve. These are all things that happen at this very critical time. And the more ACEs, the more the disruption. As a result, the way they approach emotional, social, cognitive situations also changes. If somebody has been a victim of violence, they will develop certain patterns. I might experience something that is like emotional neglect. Like I said, I might have food on the table. I might have anything I need to wear. I might have my gadgets. I might have whatever, but I don't experience love or intimacy from my family. My way of coping with it also will be affected, right? A child whose mother is unpredictable. If the child approaches the mother, the first time she hugs him, the second time he approaches the mother, she's busy and irritable. And the third time she's just, she's maybe just in a bad mood. She's like, get out of here, leave me alone. That child never knows what to expect when he approaches his mother. So he becomes vigilant. And his way of coping is largely dependent on, he's watching to see what kind of mood she's in, whether this is a good time to approach, not a good time to approach. Whereas there are people who always, no matter what the situation is, they will be received with kindness by their parents. Or even in some cases, some people are predictably bad-tempered. So not to go to that person at all. So I'm saying, there are different ways now, and that really affects the circuitry and how the person behaves. As a result, there is some impairment in their judgment and so on. There might be less impulse control in certain situations. They can't regulate their moods properly. They're constantly calibrating themselves in order to match somebody else's mood, so that they don't want to have they don't want to be noticed by the violent parent, or they want to avoid a confrontation and so on. So they lose touch with their own authentic feelings. And some of them, and in a lot of cases, they also adopt health risk behaviors like substance use, like going after adrenaline rushed activities, and because they adopt, or they might have eating disorders, they do a lot of comfort eating, or so there are many ways in which it manifests. And as a result, disease, disability, and social problems are experienced at a higher level by these people, and very, very often it might result in an early death by way of a stroke, by way of so many other diseases and so on. Now, this is a clear line that is drawn through. And so we see that a lot of these folks have issues with addiction. They have issues with substance use. Okay. And also there is clearly, there is a connection with advanced illnesses and chronic illnesses. I wanted to put that in context because I'll come back to it in a little while, that it's not always something that the person chooses to do. There are several factors that push somebody into substance use disorders. And what I shared with you just now is more from a family and social perspective. Several behaviors besides substance use produce short-term reward that may result in persistent behavior despite knowledge of adverse consequences. So it's not just taking a drug. There might be other behaviors that produce short-term reward. And neuroscientific data has led to the inclusion of non-substance behavioral addictions. Non-substance behavioral addictions. And whether an addiction is to a drug or to a behavior, the circuitry is the same. Please remember that. Whether it's to a drug or a behavior, the brain circuitry involved is the same. The purpose being to create an alternate physiological state. So, but you know, it's not only in the head. Let's talk about now behavioral addiction, an intense desire to repeat some action that is pleasing or perceived to improve well-being or capable of alleviating personal distress, despite the awareness that such an action may have negative consequences. What are some kinds of behavioral addictions that we see on a regular basis around us now? What are some of the behavioral addictions we see on a regular basis around us? Shopping.
Social
Sorry.
being awake late night.
Being awake late night. Yeah. You want to say something?
Social media content usage.
Social media? Big one. That's a big one. Yeah. So, you know, even that thing, I mean, you guys just have to do a quick Google search and, you know, what happens when you put up a post and somebody likes it and you keep going back to check how many people have liked it. You know, and you get that little bit of an endorphin hit because of it. It's the same neural circuitry as using drugs. It is the same neural circuitry. Okay. All right. Cell phone usage, yes. So there are various other behavioral addictions as well. I'm just going to keep an eye on the time. All right. Pathological gambling. That's an issue for people. I'm just going in some biological ones as well. So trichotillomania, the urge to pull out specific hairs on the body. Pyromania, impulsive, repetitive, deliberate fire setting without external reward. Kleptomania, impulsive stealing behavior without any objective need to do so. Some people don't need to, they can buy, I mean, and sometimes it's really cheap stuff also. It's not even expensive things. Compulsive, impulsive internet addiction or problematic internet use, as some of you said. Compulsive, impulsive skin picking, which is also a sign of anxiety. Okay. Most people now check their smartphones 150 times a day or every 6 minutes. I would say that's a very conservative estimate. Young adults send an average of 110 texts a day. I mean, I think this thing came out before WhatsApp and everything else, because I think it's much more than 110. Because sometimes you open your WhatsApp and you have notifications and then there are over 110 messages. 46% of smartphone users say they cannot live, not love also, but cannot live without their devices, and which is a classic sign of addictive behavior. These are not new disorders, just new targets for the universal and age-old addiction processes. Okay, so this is not something that has been brought about by, there are people who are perfectly happy not to use their phones. There are people who are not on social media. There are people who happily will put their phones off and and not worry about it. So it's not the device that causes the addiction. It's just a place for these processes to manifest. Historically known as impulse control disorders, many researchers and clinicians also use the terms behavioral addictions, process addictions, and impulsive compulsive behaviors. Okay. TV watching also. And now I think with the pandemic, what happened is we all got into the Netflix and binging on episode after season of our favorite shows and so on. And you can't stop. You're awake till 2 o'clock in the morning watching something on Netflix, and you're like, okay, this is the last episode I'm going to watch, no more. And okay, fine, I'll just watch one more. And before you know it, it's 2:33 in the morning. You can't stop. It's impulse control behavior issues, right? Okay. Some people are workaholics. It gives them pleasure to work, or they're at work all the time. Now, the difference between a workaholic, somebody who is addicted to gambling, somebody who is addicted to drugs or alcohol, is our attitude. We reward workaholics, even though it might cause harm. A person who works non-stop through the day or night and has no time to be with their families, for self-care, to look after them, to do other things that might be necessary to balance out their lives, they are actually, a lot of the times they're seen as overachievers, and their behavior is rewarded. It is causing damage in their families, isn't it? Their relationships are suffering. Their health is suffering. Their sleep is suffering. Their appetite is suffering. They're probably drinking a lot more coffee than they should. It's difficult for them to relax. So they probably, go home and probably have a drink just to unwind. But like I said, it's our attitude. We reward certain behaviors over others. And there is a lot of controversy in diagnosing, treating, or even naming conditions, as many of these behaviors are daily rituals, instrumental to our ultimate survival. Okay. Please don't mix it up with obsessive compulsive disorder. In OCD, you don't have a craving. It's more from an anxiety reduction perspective rather than a pleasure-seeking perspective. So these behaviors, the difference is this gives you pleasure, this relieves anxiety. There is a difference between the two. Okay. Yeah. Mere exposure to a substance or activity does not result in addiction. Yes, true or false? Like I said, just because you have a smartphone doesn't mean you're on social media all day, all night.
True.
All right. Some people might have a drink of alcohol, but that doesn't result in addiction.
True.
Yeah. So some people might gamble only on Diwali, right? Because it's more a cultural thing. So mere exposure to something does not result in addiction. Very important point. There has to be a pre-existing vulnerability in that person. Addiction is a human problem that resides in the drugs, or in the drug's capacity to produce physical effects. A little bit of a, this is putting responsibility on, not responsibility, but this is really shifting the perspective. So some people say, no, just being, don't ever have a sip of alcohol because I don't want you to become an alcoholic. It's not that. You have to look at what the vulnerabilities are in that person, what setting they exist in, what is the ecosystem they exist in. Now we'll talk about that. A very interesting example was that American soldiers who were serving in Vietnam in the 1960s, less than 1% used drugs before the war. When they became soldiers, they regularly started using heroin, barbiturates, and amphetamines. In fact, it was encouraged because it gave them, the wherewithal to go out there and fight. And for a lot of the soldiers, it also altered their mental state so that they could then actually go and fight in battle. 20% met the criteria for addiction at the time. But after the war, 95% of them were in remission. So that goes to show you that it's not something that you can make your way back to recovery. Okay, now I'm just going to spend a little bit of time on specifically on substance use because we've talked about the behavior and stuff, but I want to just spend a little bit of time on substance use disorders and then segue into palliative care and our relationship with controlled medicines. There are three factors that decide for substance use disorders. Has to be the availability of a drug with an addictive potential. Senior, is my network again?
Yes, ma'am. You were interrupted.
Now is it okay?
Now it's okay, ma'am.
All right. So what I was saying is For a person to develop a substance use disorder, 3 things have to be present. The person has to be susceptible, there has to be a stressor, and there has to be a drug available with addictive potential. Okay? These 3 have to be present. And what makes a person susceptible? A predisposition. Okay, it could be Is there a problem, Senior, again?
No, ma'am, you can continue.
All right. So,
Ma'am, Smriti ma'am,
yeah. Yeah.
ma'am, your connection is again interrupted.
I want to emphasize here that when I say predisposition, yes, some people are predisposed to developing addiction. Please make sure that you don't mix this up with a genetic, that addiction is genetic. Okay, I know there's a widespread belief that alcoholism is a genetically transmitted sort of condition. There is no such thing as the alcohol gene, by the way. It's a far more complex thing than that. And the latest studies will tell you that it's a combination of various elements. Yes, it shows up in families as repeating patterns. It's not because the gene is defective, it is because of certain social and familial conditions that the person is exposed to within the family. Okay, predisposition. Brain development in the uterus. If there is substance use by the mother when the child is in the uterus, it has an impact. So in that case, some children never stood a chance. Brain development in childhood, what I talked about, experience dependent versus substance dependent. Were they nurtured? Were they neglected? Were they abused? Those kind of things also severely affects brain development in childhood, and then affects their impulse control, affects their way of making choices, problem solving, etc., etc. Environmental and emotional influences in development of dopamine circuit. Now, this is a very biological thing, but dopamine is a feel-good neurotransmitter. It is released when a person engages in certain activities. If that person is not allowed to experience those activities, then they seek for overcompensation in other ways. There's also the neural circuitry of attachment and reward, endorphins and oxytocin. This is seen in intimate interactions between mothers and their children. A child needs oxytocin. It is released when there is physical connection between parents and their children and so on. If that child is deprived of it, that oxytocin receptor is not, it is affected. Okay, I'll tell you what you can read to know more about this. Regulation of emotions through neurobiological development is largely impacted by all these other factors that I told you about. Patterns of attachment, like I described, if a child does not know what to expect when he or she is approaching their mother, that style of attachment is very different from versus when a child is secure that every time he or she approaches his or her mother, he will be received with love and safety. So there is secure attachment. There are some psychologists here who will be able to tell you about that. Secure attachment, insecure attachment, avoidant, all of those things. And that also affects your susceptibility. And the impact of a nurturing adult. Who is the adult in the person's family? Okay. So the availability of the drug, the family and peer influences, environmental context, and this is just mainly a repetition or a summary of the previous few slides. Now, let's talk about how drugs are used. What are the different routes through which drugs are used? Some drugs are swallowed, some drugs are smoked, some are snorted, some are injected, generally intravenous, less common than other methods of use. Some drug use is fetishized, so there is it is anally absorbed, and some is vaginally absorbed. Some drugs are never injected, like we never marijuana, weed, charas is not injected; it is ingested or it is smoked. And there are some that are rarely injected, like cocaine and ecstasy. Now, different routes of administration carry different risks of exposure, to HIV and other bloodborne viruses. Of course, the highest risk is from injecting. So you find that a lot of substance users also who prefer the IV, the injecting route, also have HIV. And in fact, this is a huge part of what harm reduction is about, that we ask people to bring in used needles and trade them in for clean needles. It's a very controversial subject, but it really helps in actually reducing the incidence of HIV. So at least people are using clean needles and not sharing needles and then, you know, sort of transmitting other blood-borne diseases to one another. Okay, so there is an interplay there as well. And some people use several drugs at the same time, and this could be because one drug enhances the effect of the other. It could be that one drug reduces the adverse effects of the other, like when you have a side effect and you're taking another medicine for it, or to gradually replace one drug with another, either because of price, availability, or in some cases, substitution therapy also. That's what we do. Sometimes polydrug use can occur simply because a person has just lost track of what they've taken. They're so far down their journey of addiction that they no longer know what's in their system and what's not. And it can carry major risk because it can multiply the chances of adverse reactions, toxicity, overdose, and are unrelated to the level of drug use. So it's more about the drug interactions than the drug use itself. Now, there are lots of thoughts and ideas that people have about recovering from problematic or dependent drug use, but people might want to recover for various reasons. They either want to minimize their health risks, as you see with a lot of smokers quitting smoking. They realize that smoking is very, very harmful to their health, and therefore they take the steps by reducing it, or reducing the frequency, or stopping altogether. Some of these may need additional professional help. Not everybody can decide to stop and just stop. Right? So in some cases, you need harm reduction services, you might need counseling, you might need substitution therapy, and you might need management in the long run. So it entirely depends on the intensity of the use and how far down the line you were. Usually with recovery, there are two outcomes. Either the person stops using the drug completely, or they reduce the frequency and amount. Yeah. And let me also clarify that abstinence is not the only treatment. You can't say that somebody is cured and recovered only if they completely abstain. That shouldn't be the end goal for everybody, because that's not how it works for everyone. And there are a lot of misunderstandings we have around drug use. Once a person has used drugs, they can't stop is one misunderstanding. Once someone has developed drug dependence, their only chance for recovery is to never use that or any other drug for the rest of their lives. Otherwise, they'll fall off the wagon and that's it. That's the end of their recovery. These are two statements that we hear very often. For some people, yes, it can be true in some situations, but research shows that it is not true for most people. People can make a full recovery, and people don't necessarily have to stop everything in order to get over one drug addiction. And most people will recover from problematic or dependent drug use with or without treatment. Now, I know this seems like a controversial subject or statement. More and more studies are showing us that people are, once they find the right way to do it, they are invested in recovering, and a lot of them make a recovery. And this is a very important political, I think, putting it in context. For those who need treatment, and this is something that even mental health experts in India are talking about now, and this pretty much informs drug policy reform around the world. That when we work with people who want to recover, we need to approach them from a human rights basis. And what does that mean? It means that their access to recovery should be something that should be made available to them, and there should be evidence of its effectiveness. Now, we hear horrific stories of people sometimes being chained to their beds deprived of the drug, and then sometimes with a, I'm sure some of you have heard of these practices. There is no evidence that it works. There is a lot of evidence that harm reduction works. There's a lot of evidence that substitution therapy works. So we need to look at the evidence for effectiveness and it has to be provided in the community. And it has to be decriminalized. And we'll talk about that. So we know now that, that emotional nurturance is absolutely required for healthy neurobiological brain development. They are at higher and higher risk for developing all kinds of disorders. How genes express themselves is dependent on the environment. Yes? Sorry, I'll stop my video. A child can feel emotional when a parent is physically present but emotionally unavailable. This is a state which we call proximal separation, right? So just because somebody has grown up in a seemingly healthy household where the parents are there and everyone is together, it does not necessarily mean that the child got the emotional nurture they needed. Okay. And finally, children who do not receive this attentive presence of the parents are at greater risk of from external sources if they're not getting that dopamine, oxytocin, and endorphin. So I'm going to make a little bit of a segue now to palliative care and addiction, because this is, after all, a session about palliative care. Substance use disorders, for it to happen, you need a susceptible person, the availability of a drug that has addiction potential, and a stressor. Now, how significant is the experience of illness as a stressor? For a lot of people, it is one of the most stressful experiences of their lives, right? We also have to understand that it's not just the patient, but when we walk into a home and we do an assessment, is there somebody else in the family who is not the physical, who's not the registered patient, but are they at risk for substance use disorders? Is anyone in the family that we're judging too harshly? And do we have ideas and misconceptions about certain medicines, but not about others? How many people here know that morphine, tramadol, fentanyl, they're all from the same category of drugs?
Yes, opioids.
Yeah. Do you know that pentazocine is an opioid? It's a synthetic opioid. Pentazocine is given to women. It's used a lot in maternity hospitals. Do you know that now, you're being given this new generation of drugs, tapentadol and all of those? These are also opioids, synthesized opioids. Yeah. But somehow, if I say it's time to give your father morphine versus give your father tramadol 4 times a day, where do most people hesitate?
Morphine.
So this is a problem, because morphine is a gold standard for pain management for a lot of cancers. Not all, but a lot. But it's this attitude that we have, this opiophobia that we have. And now, again, I'm saying that all of these are opioids. They're all opioid-based medicines, but we have certain ideas about certain drugs than others. Unfortunately, when we have inadequate pain control, especially in a country like India, where over-the-counter medication is freely available, people do get pushed into overuse of those drugs. I'll happily take 4 dolos a day, 650 mg dolos a day, and control my pain. And I can buy it over the counter in most places, right? There might be other drugs that I might take, which might have GI tract, impact. There might be other drugs with other side effects, but we don't really stop and think about it. But the minute morphine comes into the picture, suddenly we're very, very careful that, oh my God, no, I don't want this drug. Okay, so these are constant barriers Atsung. A thought from the previous slide, children, young adults also tend to choose getting into unwanted relationships in search of their missing love and care. Yes, absolutely. Yep. And invariably that leads to similar situations where they're not treated very well. Okay. So let me come back to this. What are your thoughts on morphine and other opioids for pain relief? We just did a quick check on this right now. And let's just talk about opioids and dependence. There is a misconception that morphine is highly addictive. It is not. In its oral form, there could be some when you take opioids over a period of time, withdrawal symptoms that can occur if you suddenly stop is low energy, sleepiness, disorientation, delirium, myoclonic like spazzing, like jerky movements, abdominal cramps, and diarrhea. If you suddenly stop. But if you do a slow withdrawal of the opioids, these withdrawal symptoms can be controlled. In terms of psychological craving addiction, what we normally look out for is the person craving the substance when the pain is relatively under control? Are they asking for increased doses? Are they coming between, suppose they come to us and we give them 10 tablets for X number of days. Are they coming back in between and saying, no, I lost that packet, I need more, or, and that's a frequent thing that's happening. Is there any behavioral changes that are being reported by the family and so on? This is very, very rare with oral morphine. And when I say it doesn't happen, it's not a problem with cancers because the pain is so intense that the drug is actually combating the pain, and there's no euphoria, there's none of those other things. Oral morphine, because it is injected and it is slowly getting metabolized through the digestive tract and outwards, there's very, very, very minimal chances of any kind of addiction or dependence coming out of that. Okay, in 2002, I mean, this was also published in the Lancet, 1,723 patients were studied in Kerala. And there was a very strong system of documentation when it came to the use of opioids. And absolutely no major unaccounted discrepancies were found. And minor discrepancies that did come up were investigated by the researchers, and absolutely no misuse or diversion was reported. Now, this is a very important thing because our NDPS Act, which is the Narcotic Drugs and Psychotropic Substances Act, had undergone a change in 1985, which had made it near impossible to access opioids and other morphine and other opioids in the country, because they said that these drugs had to be highly regulated because they had higher chance of misuse and diversion. But this study actually disproved that. And we have successfully implemented the rational rules of the NDPS since rational rules of usage within our organization since 1998. And something like 175 recognized medical institutions stock dispense oral morphine for use by people in their homes. Okay, and injectable morphine and other opioids are reserved for hospitals, of course, because these might have a higher risk of dependence. And since 2002 till 2022, we have not had a single case of diversion that has been reported. Worldwide, we have this idea that we should have a principle of balance, that we should prevent the abuse of opioids and other controlled substances, but at the same time make them available for those in pain. And this is what the principle of balance looks like. You have international laws of criminal justice that are for the prevention and that prevent diversion. And there's international laws of human rights that tell you that no, being pain-free is a human right. Unfortunately, this is what it should look like. Unfortunately, this is what it looks like. Whether it's our own NDPS Act, whether it's the drug policies across the world, this is what it looks like. People talk more about avoiding addiction than actually treating pain. And typically there's a language around we should either control it or we should grant access. They're seen as two sides. And the arguments are always made in terms of harm versus value, restrictive versus enabling. The balance, as we see it now more and more, and some of us have come together as 2 Lancet commissions on addiction as well as on pain relief have come together. What we are saying that is that whatever it is, it has to be a patient-centric approach. And the focus should be on the suffering of the individual and the families. How much is that person suffering, and how much of that suffering can be alleviated if we give them access to the right medicines? And we must focus on safe access, and we have evidence for that. And of course, we have to work with the government and the doctors and train professionals, as well as people like people in civil society. This is the current trend of how opioid analgesics are used across the world. It tells you in terms of consumption, which countries have what they need and the estimated needs met. And you will find that entire countries disappear off this map. That means they do not have access. And if you take a closer look, you'll realize that most of the countries that do not have access are erstwhile colonies. By now, you must be very familiar with this man. We found him like this. He was like this for 3 weeks, doubled over in pain. 3 weeks. And 1 dose of oral morphine enabled him to sit up and have a cup of tea. The fact that we are denying people this is a real travesty of justice. So I would like to that I feel like everybody should definitely, who's interested, should definitely read it. It's written by Gabor Mate, and Gabor Mate actually has also got 20 years of experience in palliative care. And it pretty much changed the way I look at addiction and substance use disorders. And I feel like it goes a long way for us to really, get past our misconceptions and ideas about addiction. There's this beautiful quote from this book that says, if mental health is the poor sister of the health system, then addiction is probably the second cousin who lives in the slums. We don't really want to deal with anybody who has a bad problem with addiction. And what they recommend is that rather than asking what someone is addicted to, when they got addicted or for how long, try asking them, what does it offer you? What do you like about it? And what in the short term does it give you that you craved or liked so much? And inevitably, one of the answers you'll get is, it helped me escape emotional pain. It helped me deal with stress. It gave me peace of mind. It gave me a sense of control. It helped me to connect with others. And such responses illuminate that addiction is neither a choice nor primarily a disease. It originates in a human being's desperate attempt to solve a problem, the problem of emotional pain, overwhelming stress, of lost connection, of loss of control, of deep discomfort with the self. In short, it is a forlorn attempt to solve the problem of human pain. All drugs and all behaviors of addiction, substance dependence or not, whether gambling, sex, the internet, or cocaine, either soothe pain directly or distract from it. The question is not why the addiction, but why the pain. And I thought that was a very, very powerful perspective. And worldwide, we are trying to see, we're trying to move along in a shift from criminalization and abstinence to harm reduction. And now, after having seen all of this, let's visit Mrs. A's family again. Nothing has changed, the story is the same. But now that you have all this information, I just want you to think about whether your approach will change in any way, in how you will tackle this family. And I'm just going to close with one last, series of paragraphs. This is from Johan Hari. There's a really, really great TED talk by him. I'll share his name with you. One cannot make war on inanimate objects, only on human beings. And the people we are attacking are the same ones that evidence has proven have been the most neglected and oppressed in childhood. According to all science and epidemiological data, all experience, they are most likely to succumb to substance addiction later in life. In our civilized times, we are punishing and tormenting people for having suffered trauma. So the opposite of addiction is not sobriety, the opposite of addiction is connection. And that is something that we all probably need to revisit in our minds and take on a more compassionate view. We talk about compassion in palliative care. There are certain conditions that it's not easy to be compassionate towards. Addiction is one of them. And the ones that are most difficult to be compassionate towards are probably the ones that really need it. So I'm going to stop with that. And if there are any questions, any comments, any reflections, I'm happy to take them. Otherwise, we can call it a day.
What would your answer be for the Mrs. A's family?
Oh, my answer would be, of course, see, multidisciplinary approach. Like so many of you said, that all of them need help, and it's not necessary that we have the resources and the time to address them all. But my hope from the group was just that, you know, it was very easy to earlier blame the father and paint him as a villain, and also to not, you know, quite understand what the youngest son was doing. But I wonder if there was some room, and we know that people with addictions are notoriously difficult to convince that they even have a problem, right? So what would be my approach is, I would, at least at the very start of it, try and take a more compassionate view to the husband, because it's very easy to villainize somebody. My first thing would be to try and control her pain in a safe way, because being a palliative care team, that's probably why we were called in. And I would pay special attention to the younger son, because he is living in a very traumatizing setup. And who is the other invisible patient is probably the other son as well, but he's just not expressing it. There are no
So
right.
you just said everyone, right? Like the rest of us?
Yeah, but then, yeah, absolutely. It was not an easy, there was no perfect solution to this family.
To take your own question, which one do you think really sort of needs palliative care?
See, Swarnalata quizzing me back.
I'm putting the same question back to you, that's all.
Yeah, I know. Who would I prioritize? Yeah. It would depend on the level of pain the woman was in, because if she's in pain.
The question, your story gives you everything.
Hmm.
Given that story, given whatever data you've given, pick out one person whom you will say needs the most.
That's what I'm answering. I will go with the mother first, because when someone is in excruciating pain in the family, it causes other people to also develop very dysfunctional coping styles. If I have somebody screaming in pain in my home, if I have a problem with addiction, I'm going to go deeper into the addiction. If I am not able to talk to my mother and I'm helpless, I'm going to go and engage in other activities as well. So she would be my first. Bringing her pain under control would be my first priority. But I would then definitely, my next line would be with the son and the father.
Yes. Right. Thank you.
You're welcome. Are there any other questions or any other comments or reflections? Was there anything here today that was perhaps a new perspective, or maybe you don't agree with it even?
I feel there are people using substances, not exactly as experimenting or relaxation, but and I don't think some of them have any really ace as part of their bringing up, or rather growing up years, but still they get into it. Do you have an explanation for that?
How do we know? See, because just please remember that it doesn't have to be direct abuse. Neglect is a huge kind of abuse as well. Like I said, a person who did not get emotional intimacy as a child is as susceptible to substance use later as somebody who was physically abused?
Is it that they've been using it and that got used to it and enjoy it, rather than any sort of a neglect also?
It's hard for me to generalize like that, Swarnalata. It'll have to be on a very case-to-case basis because some of these things are very nuanced. I will, so I wouldn't say no, they just started using it, enjoyed it and got hooked to it. There has to be something maintaining that behavior, in my opinion. Especially when you know that the adverse effects on the family and stuff are great. So there is something maintaining that behavior.
What about if you have a gifted child, a burnout? Do they get into that?
Pardon me?
Gifted child burnout?
Hmm?
Do they get into any of these abusive behaviors?
I don't think I can answer that question as a cause and effect or something that will happen. It depends entirely on a case-to-case basis. And if you're saying gifted child burnout and stuff, I would say that intrinsically there's a lot of pressure on that child.
It need not be from the external environment. It could be a self-inflicted one.
I didn't understand that.
It need not from an external environment. No one is pushing that kid to be a sort of a performer.
Okay, would anyone else like to respond to that? Because I know there are lots of psychologists here in this group. I don't, when somebody is labeled a gifted child, I don't think that, I don't know if, even if it's not explicitly expressed, I think the pressure is there somehow. So, but I'm just going to invite other people in this group also to respond to that.
The terminologies and the cases are not clear to us, so we don't.
I think the whole point was to also express the fact that addiction is a very, very, very complex condition. There is no straight line that you can draw from one event or one experience to the fact that this is what drove them to it finally, or whatever. So I would say that's the whole point of this, that we have to look at this, the social context, the physical context, the emotional context, the biological context. Yes, some people are more predisposed. But see, you can have a susceptible person, the availability of a drug, but you may not have that kind of a stressor that pushes them into it. Or you might have all three. So I wouldn't say, I wouldn't be comfortable really putting them in boxes like that, where I can say that, yes, if this happens, then this is likely to happen, like, for sure. So it's inconclusive. I know my response is inconclusive, but I would need a lot more detail on that case before I could make any sort of, committed statements.
Excuse me, ma'am.
Okay. Yes, Hema.
Yeah, doesn't it also depend on the mental strength of the person? I mean, there may be all these, situations and things, but if the person is strong enough, will they be able to control themselves?
I would reframe. See, we all use that phrase mental strength. What is mental strength and tenacity? Is it the ability to reframe a problem? Is it the ability to reach for a better coping mechanism? Is it the ability to unpack, rethink, reimagine another solution? So mental strength, I'm not quite sure what that, like, is it, in this case, are you saying it's my willpower, I just won't do it?
Yeah, in the sense of, I'm not saying it will solve the problem, but what if, you know that it's a problem, and you are going through it, but you say, okay, I will not, go to this kind of a resort to ease myself, probably do something else. That's what I meant by mental strength.
Yeah. So this is, okay. So you're saying before even getting into
Yes.
an cycle.
Yes.
Again, I'll come back to the fact that some addictions are visible and some are not. Some addictions are condoned and some are not. That's what I said. Society sometimes rewards certain addictive patterns and doesn't reward and punishes another. If you are working long hours, I'm going to restate this and say, hey, I'm not going to drink, I'm not going to smoke, I'm not going to take a sleeping tablet. What I'll do is I'll stay up and I'll finish my reports. So that, you know, and you stay up till 3 o'clock in the morning working. Now, your same circuitry is being used, right? You're doing this because you're also, you might be stressed out. I mean, a lot of people, to them, their way of centering themselves and maybe getting away from work, from home stress, is to go to work, because it keeps them away from dealing with emotional issues. Which of the two is better or worse? If this person is like working so hard that they're not eating on time, that they're not nurturing their relationships and stuff. When we talk about addiction, we say engaging in a behavior or in something in spite of knowing the adverse effects. Right? There are adverse effects to this as well. So I'm glad we're having this conversation, because this is it about addiction. It's not black and white. It's not binary. There are so many complex issues at play here. And if the first thing that we can do is perhaps take on a little bit more of a compassionate view and understand that all of us have some addictions in some way or form. Every single one of us. It's just that in some people it's celebrated, and in some people it's vilified. So so Hema, but yeah, if I guess some people do have that tenacity. There are people who've grown up in households where they've seen and witnessed a lot of substance use disorder. So they say, I will never touch a cigarette in my life. I will never touch any substance in my life, because I know that I have the, yeah, they might do that, but let's see what else they're doing in their lives.
True. Yeah, the idea of other things also being addiction, which we normally don't look at as addictions. Yeah, I guess we probably would turn to that. So I also had another thought. Would being antisocial also be a kind of I wouldn't call it, I don't know if we call it an addiction, because suppose a situation, something like what I was speaking about. So something is troubling me, and I don't want to get into any of these known forms of addictions. So I just internalize, I just keep it to myself, and I start becoming more and more antisocial, because every time I face the situation, I just shut off. So what would you say for that? Would you call that also? I mean, it is a form of getting away from your pain and whatever is troubling you, right?
Yeah, but is there a craving for that state? Is there lack of impulse control? Is there,
True, right.
Look at the factors. Look at the factors there. Yeah.
Yeah, true. Thank you.
Asocial behavior, antisocial. Yeah, and antisocial is more a pathological term. Asocial is when you're more withdrawn and.
Okay, sorry.
Okay. I think we're at the end of our time today. Thank you all very much for staying through the session and for this enriching discussion at the end. And I'll be happy to, if there are any questions, you can send them in, and I'm sure the Pallium team will send them to me. So I will sign off now, Senior, and I'll let you.
Thank you, madam. Thank you all. Good discussions, academic, clinical.
Thank you, Smriti ma'am, and thank you all for being with us today. And I'm expecting you to be present in next class with your videos on, and have shared the feedback link with you. That's in the chat box. Please do fill that form, and I will be sharing it in the WhatsApp group also. And thank you once again, and we'll see you on the next class. Bye.
Thank you.